Hi, everyone. Welcome to the Okanogan County and Washington State Department of Health COVID-19 vaccine webinar. We're so excited you're joining us for this exciting event today. My name is Jessica Kuzma. I'm here with Okanogan County Public Health, and I'm joined by a great team from Washington State Department of Health and some Zoom tech experts as well. So thanks to everyone for being here today. The agenda for today is as follows. We will have 3 short presentations from our panel of guest physicians, followed by discussions in small groups. You'll be placed automatically into rooms with colleagues to discuss your experiences with providing the COVID vaccine to patients, and you'll be joined by one of our guest presenters in each room to facilitate those discussions. And the presentation portion of the webinar is being recorded today. However, the breakout rooms will not be recorded. After the discussion groups, we'll come back together as a group, and I'll ask for someone from each group to share a little helpful takeaway that they might have learned today. We might have time for a question or two at that point, but I'll encourage you to join us for part 2 next week, Tuesday, July 20th from 12 to 1, where our guest presenters from today will be joined by Dr. Jim Wallace, our Okanogan County Health Officer, and we'll have more opportunity for panel discussion at that point as well. So now it is my pleasure to introduce our speakers for today. First up, we'll hear from Dr. Bob Lutz. Dr. Lutz is a board-certified family medicine physician with more than 30 years experience in urgent care. He served on the Spokane Regional Health District's Board of Health for 8 years and was the health officer for Spokane County until 2020 and currently serves as the health officer for Asotin County. Additionally, Dr. Lutz is a board member on the Washington State Board of Health and medical advisor for the COVID-19 response for the Department of Health. Thanks for joining us today, Dr. Lutz. Next, we'll hear from Dr. John Merrill Steskel. He is with us today, a practicing family physician in Ellensburg, Washington. He regularly engages in discussions about the benefits of vaccines through his community radio show, his medical blog, and presentations to healthcare providers and medical students. Dr. Merrill Steskel was awarded the CDC Childhood Immunization Champion Award for Washington State in 2018, and he's affiliated with Kittitas Valley Healthcare and is a clinical assistant professor for the University of Washington. He also serves as representative for the Washington Academy of Family Physicians on the Washington State Department of Health Vaccine Advisory Committee. We're thrilled that he's joining us today. And next we have Dr. Elias Cass. He's a doctor in naturopathic medicine practicing in the Seattle area. Dr. Cass specializes in the naturopathic primary care of babies and children, including immunizations. Dr. Cass has previously been a professional member of the Midwives Association of Washington State, and he's currently a member of the Naturopathic Association of Primary Care Physicians, the Washington chapter of the American Academy of Pediatrics, and writes for ndsforvaccines.com. In 2017, Dr. Cass was the first ever ND to be recognized as the CDC Childhood Immunization Champion for Washington State. We're so privileged to have all of you joining us today. Thank you so much. Next slide, please. Lastly, the planners and speakers of this activity have no relevant financial relationships with any commercial interests pertaining to this activity. Information about obtaining CEs will be available at the end of the webinar. And next slide, please. The continuing nursing education activity was approved by Montana Nurses Association, an accredited approver with distinction by the American Nurses Credentialing Center's Commission on Accreditation. Upon successful completion of this activity, 1 credit hour will be awarded. And this program has also been granted approval by the American Association of Medical Assistants for 1 administrative continuing education unit. And this training was approved by the Washington State Pharmacy Quality Assurance Commission for pharmacist education. Upon successful completion of the activity, 1 credit hour of continuing education will be awarded. Okay, next slide. This is the objective slide, which we'll skip for now, and we'll move on to the next slide, please. And it is my pleasure to introduce Dr. Bob Lutz. Take it away.
Hey, good afternoon, everyone. Thank you, Jessica. Next slide, please. So what I'd like to do in the next couple of minutes is just provide you an overview of where we are right now. This is a model, this is a slide based from the Institute of Disease Modeling, looking at our effective R naught. And as you can see, we're above that line of 1. We like to keep our numbers below 1. That means that with 1 infection, we do not necessarily have 1 transmission infection, which is good. We're inching up a little bit above that, but as you can see, the last couple of weeks, we've been below that level. Next. These, again, it'd be an interesting snapshot of looking at King County versus Benton Franklin. I'll provide some other snapshots, but you can see as a comparison point where, again, given vaccinations and given disease transmission in King County, quite different than what we're seeing in Benton Franklin and Eastern Washington. Next slide. This is prevalence. And again, prevalence right now remains less than 0.2%, which is good. Next slide. Again, a comparison of prevalence in King County and Benton Franklin. You can see that decline in King County and rather an uptick in Benton Franklin. Next slide. Statewide trends for positivity, for hospital admissions and mortality, essentially decreasing in the positivity rates and hospital admissions, a little plateauing in daily mortality. Next slide. And then trends in cases by age, and you can see declines in all age groups, which is encouraging. Next slide. This is just incidence rate based on data from last week. And as you can see, our numbers have remained sort of constant. We have seen decreases. It's encouraging to see our incidence rate decreasing now to 67.6 per 100,000 over 2 weeks from last week. Next slide. And this is just our epi curve, and you can see where we are now in comparison to where we were in the past. And right now, our incidence rate is approximating where we were back in the summer of 2020. Next slide. Just wanted to give you a snapshot of other epi curves, and this is Chelan County. You can see this. Next slide. Douglas County, so your neighboring counties from Okanogan, and then finally, next slide, Ferry County. And then finally, next slide, please, Okanogan County. And certainly of the 4 counties I've just presented, Okanogan unfortunately still has the highest incidence rate of those 4 counties per data from last week. Next slide. Next slide. So we want to look at hospitalization rates. And again, you can see essentially decreases in all age groups for the most part, which is encouraging, especially in some of the younger age groups. Next slide. These are data from WA Health, and certainly a significant decrease in hospitalizations from previous surges in the past, both most recent as well as over the winter months. Next slide. Just looking at occupancy, and again, hospital beds in the blue curve at the top, ICU beds on the bottom curve on the and in red, and certainly decreases in the number of patients hospitalized, but a somewhat plateauing of cases in ICU beds, and that has been a challenge over the past couple of weeks. I want to mention that we're seeing ICUs sometimes stressed, not only because of COVID, but more so because of other patients in ICUs for other reasons. Next slide. And bear with the lines that moved a little bit on this, but what I wanted to demonstrate, these are modeling data. And again, you can compare the red curve to the green curve. And although the vertical line has drifted, what you can see is that modeling data suggests that vaccination rates or vaccination of those under the age of 64 and older than 45 imparts a 17 times lesser likelihood of hospital admissions. And for those over 65, a 13 times lesser rate of hospitalization. So vaccines work. Next slide. Next slide. Just a quick piece on variants. The graph on the left shows you the significantly increasing proportion of variants of concern that we are identifying in Washington state. You can see that in just comparing the 2 bars on the right, we've gone from almost 12% to almost 28% in just a single 2-week period. And then the table on the right shows you the different variants that have been picked up across the state. Certainly by far and away, the most we have seen is Alpha, but fast picking up are both the Gamma as well as the Delta variants. Next slide. And then just again, in proportion, you can see that whereas just a few months ago, even a few weeks ago, the alpha variant, the B.1.1.7, was definitely the predominant variant. This is being quickly surpassed by the very rapid growth in primarily the Delta variant and somewhat in the Gamma variant, but especially the Delta variant. Next slide. And this is just again attributions of the different variants. We know that all are more transmissible. We are definitely aware of the fact that all cause more severe disease. And then just demonstrating some of the effectiveness of the vaccines. Vaccines are effective for all of these variants at this point. Next slide. Next slide. And just this is where we were today. I heard that we were 69.8%. So we're almost at that magical 70% for 16 plus in Washington state. You can see the bottom graph demonstrates by age groups where we have the most individuals, Washingtonians, vaccinated. Not surprisingly, we see highest proportions in our seniors that were first to get vaccination availability. Next slide. And then just a couple of comparison slides, again, looking at Chelan County, and these were data from a few days ago, so they may be increased a little bit from Chelan. Next slide. Douglas. Next slide. And then next slide. So Okanogan County definitely doing well in comparison to some other counties, but nonetheless, vaccines are why we're here today to talk about how we can get those numbers increased even more so. Next slide. And again, just going back to these comparisons, these slides demonstrate, if you will, immunity derived from vaccination, which is your purple, immunity derived from infection, your natural immunity, and then the overall estimated immunity. And you can see certainly that Benton Franklin had more disease over its course of the pandemic in contrast to King County. But King County, because of higher rates of vaccination, have higher overall levels of immunity. And in spite of some of the rhetoric that we have out there, vaccine-based immunity does, at least at this point, demonstrate superiority over natural immunity. Next slide. And that's it. Thank you.
Great, thanks, Bob. This is it's an honor to be here to talk about vaccines, the COVID-19 vaccines. Next slide, please. What I'd like to do today is talk about what vaccines we have available, their effectiveness and safety, with an eye towards sharing information that is helpful in your discussions with patients and community members. Next slide. Messenger RNA vaccines. Briefly, I think many people know pretty much how they work. The important issue here is that patients oftentimes say these vaccines are so new, and how do we know that they're safe? How do they know that they're effective? And in actuality, we have about 30 years of research going into these mRNA vaccines. And it took the pandemic to bring them into the limelight. The main breakthrough was not in creating the messenger RNA, but figuring out how to get that messenger RNA into the body's cells without getting broken down. And that was with this lipid nanoparticle coating or fatty globule that protected the messenger RNA as it entered the cell. Each of these vaccines are 2 doses and require ultra cold temperature storage requirements. Next slide, please. This is a slide that I have shown multiple times during this pandemic. It's by a web humorist called XKCD, who does science humor. And as you can see from the slide, it says statistics tip. Always try to get data that's good enough that you don't need statistics to do statistics on it. You've got a graph of the placebo group and the vaccine group, and everyone can see that there's a huge difference. And next slide, please. And the reason I show this this comic is because it is a representation of what we know about the clinical trials and data from both the Pfizer and Moderna vaccine. Here's the Pfizer vaccine. It looks pretty much like that webcomic, and there's a clear difference between the placebo and the vaccinated group. We don't need special statistics, data analysis on this to realize how effective these vaccines are. Next slide, please. And here's the Moderna vaccine, which looks pretty much the same. Next slide, please. Next slide, please. So effectiveness, these vaccines are truly amazing vaccines. And saying these, both the Moderna and the Pfizer vaccines, you could think of them as twin sisters or twin brothers. They're 90 to 95% effective at preventing COVID-19 in clinical trials after 2 doses. And what's more, the real world effectiveness, so in other words, how these vaccines have performed well after implementation, shows they've been 90 to 95% effective out in the real world. Their effectiveness has remained stable and is similar across the various variants, which is very reassuring. Vaccination is recommended even for those who have experienced COVID-19 illness. And there are some recent studies on this that are very exciting. For one, we have good evidence that vaccine-induced immunity is actually better than getting the natural infection. Then that for those who have had the natural infection and get vaccinated, those individuals have the best immunity, about a 5 to 10-fold higher antibody levels than those who have been vaccinated, who have higher antibody levels than those who have just had natural infection. So talking to patients, you can frame it in the sense that getting vaccinated after having had COVID, they could think of it as a booster, as it prevents reinfection. Reinfection after the natural infection is not common, but it can certainly happen. Next slide, please. The Pfizer and Moderna vaccines, they're very similar. The main difference is dosing intervals from the first to the second dose and the minimum age. Pfizer now is at age 12 and Moderna minimum age is 18. Early on in their implementation, there was a recommendation that they shouldn't be given within 2 weeks of any other vaccine, but this has been removed. They can be given without respect to whether or not another vaccine has been given recently or at the same time, for that matter. Next slide, please. Briefly, vaccine safety in the United States. So this is a very busy slide, but it encapsulates our vaccine safety monitoring system, which is really helpful to be aware of in talking to patients about vaccines. In my opinion, and in many individuals' opinions, the vaccine safety system in the United States is probably one of the best in the world. We have multiple overlapping methods of monitoring our vaccines for safety. Most have heard about the VAERS, Vaccine Adverse Events Reporting System. That's a passive system, so that anybody can report to that, clinicians, patients, and it's the way to think of it is as a red flag, as a early warning system. It does not establish cause and effect, but simply alerts us to the possibility that an adverse event may be related to a vaccine and may warrant further investigation. The VAERS system has been instrumental in identifying all the adverse events that we've seen with these vaccines. We have also active surveillance, which the newest of which is vSafe, and which is an active monitoring system, a voluntary system one can sign up for at the time of vaccination, and the vaccine safety data link, which are a series of centers around the country that actively monitor patients after getting vaccines. And furthermore, the FDA has its own surveillance system. So we have multiple overlapping safety monitoring systems in the United States that really ensure a very safe vaccination system within our country. Next slide, please. So how safe are messenger RNA vaccines? As many know, the mild to moderate transient side effects are very common. The first potential problem noted with messenger RNA vaccines was the anaphylaxis, which was something identified through VAERS. And after this, so to say, the smoke is settled and we have more and more data on these vaccines, we do know that anaphylaxis happens a little bit more often in these vaccines than in placebo, 2 to 5 cases for every million vaccines administered. Anytime we inject anything into a human body, be it a medication or a vaccine, there's a 1 case per million, roughly, case of anaphylaxis event. So it's just slightly above that baseline 1 in a million chance. Most reactions occur within 15 minutes of getting the vaccine. They're very treatable, and that's why recipients are observed for at least 15 minutes following vaccination. Next slide, please. Myocarditis, that's a relatively problem identified with the messenger RNA vaccines, also identified initially through the VAERS system. The incidence seems to be, and we'll have, again, we need more time, more data to really iron out the numbers, but probably about 12.6 cases per million doses given. And the annual baseline incidence of myocarditis is about 8 cases per 1 million. So it's a little bit higher than that. Common symptoms, chest pain, shortness of breath, abnormal ECG, elevated cardiac enzymes, palpitations, and it's primarily been observed in younger recipients, males 12 to 29, most commonly after the second dose within 3 to 5 days of getting that dose. And of importance, these episodes, these myocarditis cases tend to be mild, transient, and patients recover fully. Next slide, please. This is a slide from the CDC ACIP meeting talking about myocarditis, and it illustrates how the CDC looks at these adverse events associated with vaccines. You know, what is the risk of the event versus what is the benefit of receiving the vaccine? And you can see from the slide that the hospitalizations prevented by getting vaccinated far outweigh the cases of myocarditis, which again are transient and generally mild. Next slide, please. So switching gears a little bit to the viral vector COVID-19 vaccines. So in the United States, it's the Jansen or J&J vaccine and the AstraZeneca vaccine in Europe. Also, these vaccines have had decades of research, and they are used in vaccines for the Zika and Ebola virus. They utilize a common cold virus that cannot replicate to deliver DNA into our cells to create the spike protein. The main advantage with this vaccine, the Janssen vaccine, is it's a single dose and can be stored at refrigerator temperature. So it's a lot more convenient and can be used to reach populations not as easily reached with the other vaccines. Next slide, please. Effectiveness. The one may hear in conversations or press that they're not as good as the messenger RNA vaccines, that sort of thing. And on one hand, yes, that may be true as far as effectiveness, but in terms of preventing COVID, they do what we need them to do. It does what we need it to do. It's about 66 at preventing COVID-19, 93% effective at preventing COVID-19 hospitalization, which is very important, and nearly 100% effective at preventing death from COVID-19. And also the effectiveness seems to be preserved across variants. So this is a very helpful vaccine. Next slide, please. So, and this is the Jansen vaccine is a great example of how well our vaccine safety system works. Within 6 weeks of initiation, a very serious but rare side effect was, or adverse event was noted, called thrombosis with thrombocytopenia syndrome. This is an immune system mediated adverse event that causes blood clots in unusual places. It was also observed with the AstraZeneca vaccine. And the highest risk seems to be in women less than 50, about 7 cases per million. And it prompted a 1-week pause in using this vaccine for the CDC to evaluate, well, is this safe to continue or not? Next slide. And this is just a timeline to illustrate how well our vaccine safety system works. On March 2nd, the vaccination began with the Janssen vaccine. On April 13, just 6 weeks afterwards, the CDC and FDA recommended a pause so that it could be evaluated. Next slide, please. And this is just a bar graph of looking at adverse events and the thrombosis syndrome is in that very rare side of the graph, and this is just in the women less than 50 who are at highest risk for this problem. Next slide. And if you compare it to women taking oral contraceptives, you can see that such a commonly prescribed medication has actually greater risks that are more that patients accept every day that when they take those medications than the Janssen vaccine adverse side effect or adverse event. Next slide, please. And then again, here's the CDC bar graph looking at the benefits and risks. Again, this is just women less than 50 who are at highest risk for this problem. With per 1 million doses, we can expect 7 of these thrombosis with thrombocytopenia syndrome cases. But in accepting that, we save 116 women from death and 2,638 women from hospitalization due to COVID. And for that reason, the CDC chose to continue with the Janssen vaccine because the benefits far outweighed the risks. Next slide, please. In summary, the messenger RNA vaccines and the Janssen viral vector vaccines work. They do what they need, what we need them to do. They prevent COVID-19 infection. They prevent death. The vaccines are safe. And remarkably, and a really great conversation point with patients is that existing safety concerns, they are there. They are rare, depending on the vaccine and the adverse event, but they've been identified in a timely fashion and in a transparent manner, and the benefits and the risks have been looked at and evaluated, and the decision appropriately has been to continue vaccination in each instance because of how beneficial these vaccines are at preventing COVID. Next slide, please. Great, and with that, I'd like to turn it over to Elias. Thank you for your time and allowing me to share information about the COVID-19 vaccines.
Thanks, John. So we've heard a lot of technical information about the vaccines, about the disease trends, and it's often not the technical information that is really what speaks to patients. And so I want to talk a little bit about how we talk to patients and how we listen to patients with what their concerns are. Next slide, please. So this is an incredibly oversimplified slide, but the question is there from patients about why they should be immunized. And it seems like an obvious thing, but what I like to talk about is that even though the vaccine doesn't prevent every single infection, it does prevent a lot of infections. So right off the bat, you're less likely to get infected if you're immunized. If you do get infected when you're immunized, it's far less likely to be a serious infection. So you're far less likely to be admitted to the hospital. You're far less likely to have complications. You're far less likely to have long COVID. And you're far, 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 far less likely to die. The other thing that happens with infection is that every time somebody is infected, that virus is multiplying in their body. And there's millions of copies of the virus in their body. And every time that virus copies itself, it has the opportunity to introduce an error. So it's just like somebody, like a scribe in the olden days, copying things down. Every time they copy something down, it's possible that they're introducing an error. And those are variants. So those errors are mutations, variations that have different properties. And so every time you get infected, you're not immunized, and that virus has the opportunity to replicate uninhibited in your body, those are opportunities for variants to arise, and then you're passing them on to other people. So immunization protects yourself, but it also reduces the risk of these variants continuing to arise. Next slide, please. One of the things that I hear a lot when I talk to patients about immunizing is, why should we bother to immunize given that we have treatments? But the reality is that even though there have been a lot of treatments that we thought might be helpful, they really don't work that well. So mostly these are a swing and a miss, and it's always worth swinging, right? Like, it's good that these were investigated, that trials were done, but when the big trials are done, they see that these treatments don't really work. But the vaccines really do work. So even though there are really, really small risks associated with the vaccine, it's really important to prevent these infections for all the reasons that we just talked about. Next slide, please. So when I talk about immunization, I talk about the difference between sort of general understanding and really specific learning. And so when you talk to patients, you can talk to them about their interests and then try to find metaphors or analogies that work with their interest. So one of the things when I'm talking with parents or with teens is driving. So if you get in a car, you've never seen a car before, and you go on the highway, you might figure out how to drive. Like, you might figure out how the steering wheel works, how the gas pedal works, how the brakes work, but it's really likely that you are going to damage yourself, the car, or somebody else as you're figuring it out. Whereas immunization is like going to driver's ed, where you get to learn about cars, about how they work, how to drive. You use a simulator, you take training drives. And so the immunization is a chance for your body, for your immune system, to learn about the virus before it encounters it. So when it does encounter the virus, it knows how to respond, and it can respond really quickly, generate those antibodies to fight really effectively. So we support the immune system broadly with good food, exercise, fresh air, like all those things that are good, but those broad things do not replace the really specific training. So like using an air conditioner is not a replacement for going to an HVAC training and learning how to do HVAC systems. Knowing how to drive even is not a replacement for knowing like car mechanics and being able to take apart a car and put it back together. So whatever things your patients are interested in, you can talk with them about general understanding and really specific learning. Next slide, please. So I am a naturopathic doctor, and the naturopathic community, or people who are interested in natural health, are often more reluctant to take vaccines and to give vaccines to their kids. And so myself and a bunch of other naturopaths have started this blog called ndsforvaccines.com. And we've been writing for a couple of years now. And we have lots of resources available that are written from a naturopathic perspective. So if you have patients who are more interested in natural health and who think that no naturopath would vaccinate, or they have very specific things about naturopathic medicine, you can refer them to our blog. If there are things that you would like us to address, feel free to send us a message and we'll put together an article. There's another article coming pretty soon about COVID. Next slide, please. This is a really cool resource from the University of Minnesota, I think. And this has lots and lots of different kinds of resources. They have short fact sheets, long fact sheets. They have them in lots of different languages. They have them customizable. They have social media stuff. So I thought this was a really cool resource because I know we all know about the CDC and the DOH, but sometimes patients aren't interested in sort of government level information. And so some of these lesser known resources that are still really comprehensive can be really helpful. It's also helpful to be able to answer questions. So one of the biggest things when talking to patients about vaccine is to ask questions and to really listen and then ask follow-up questions. So you asking questions is how you demonstrate to your patients that you're listening. And so your first conversation about vaccines might not involve you giving any information at all. It might be totally like, tell me about your concerns. Tell me about that concern. So maybe they knew somebody who got the vaccine and got sick anyway. Maybe they knew somebody who got a vaccine and they had a side effect. Maybe they don't know anybody who's gotten COVID and they don't really think that it exists. So you can't really speak to their concern without knowing what their concerns are. And so asking questions is a really great way to open up the conversation for you to listen. You don't have to answer things right away. You can say, oh, I'll find out. You can browse these resources together with patients. Sometimes that's helpful. There's a site called immunized.org that's really helpful. I didn't put a slide about it, but they have a patient-facing kind of site and a physician or a provider-facing site. And I actually like to browse the provider-facing site with families so that they can see what we're seeing, so that they can see the level of complexity and how we do appreciate that there are adverse effects, that we do appreciate that it's a hard decision sometimes, but that the math does come out in favor of vaccinating and preventing infections. Next slide, please. They also have a lot of cool resources at this National Resource Center for refugees, immigrants, and migrants about debunking and addressing misinformation. So these can be good resources to have in your office, your clinic, or wherever you're working. If you're being asked questions that you don't know the answer to, sometimes the really technical questions are sort of gotcha questions, like, oh, you're never going to be able to answer this. And sometimes they're actually real questions. So it's really nice to have these resources available so that you can answer those questions. Next slide, please. This is another really, really, really great technical question site. So this is called PlatformDiseasecom. I think he's actually local to Washington, and he's written a lot of really cool articles that dig really deep into the weeds. So, you know, do the vaccines prevent long COVID? Probably. What about, like, why did the flu go away this year? Do vaccines cause infertility? He's got lots and lots of really specific, really technical information here. Next slide. And then we've got a whole long list of additional resources. I think there have been so many resources put together for COVID vaccine confidence and hesitancy and talking to people that sometimes it can be really overwhelming to know where to start. So the Immunization Action Coalition, that's the immunized.org. The Children's Hospital of Philadelphia has really great resources, especially for families. So you can sort of go through and try to decide which ones would be most helpful for your patients. It's definitely best to pick one or two or maybe three to share with your patients and not just a whole long list, because nobody's going to actually go through a whole long list. It just sort of like blurs into nothing. And I think that that's all that I've got. Thank you.
Great. Thank you so much. Those were fantastic information sessions and some fantastic resources. We'll be sharing copies of the slides after the fact, so you'll have access to that list of resources that Dr. Cass shared. Thank you. So now what we'd like to do is break up into some small group discussions. This is just an opportunity to exchange information among peers and to share challenges and successes around providing or discussing the COVID-19 vaccine. Each one of our presenters will be in a room with you, and feel free to ask questions, discuss, and share, exchange information. Breakout rooms, as a reminder, are not being recorded, so feel free to speak freely. And you'll be assigned automatically, and then you'll be brought back together as a group automatically as well. If you're not put into a group, just be patient. You'll be placed momentarily. So thank you, and we'll see you back in about 15 minutes. Hi, everyone. Welcome back. Thanks for participating in the breakout rooms. Hopefully you had an opportunity for some lively discussion, some sharing of ideas and information. In our last few minutes here, maybe we could just go around real quick and someone from each group can share a little tidbit they learned that was helpful from their session. Would someone from Dr. Lutz's group like to share real quick?
Well, Jessica, hearing no one, I will chime in. What I think one of the messages was that if you can provide people information that they can relate to, so for example, talking to them about past vaccinations, or about, for example, if they've had children who've been vaccinated. Yes, you were a little fussy after the situation, but you know what? At the end of the day, everything was good. So trying to make it relatable to things that people have experienced in the past was just one observation that one of the panel, I should say one of the members had.
Fantastic. Great point. Thank you. How about someone from Dr. John Merrill Feskel's group? Anything enlightening to share with the group there?
Yeah, I'll follow Bob's suit. Yeah, we had, I think, great discussion, and I'm just struck by all the great people out in our state working hard to talk to people about COVID vaccines. But one thing that came up that I think is really helpful to think about for everyone is that, you know, there are certain groups, population subsets that tend to be against vaccination, and to try to improve vaccination rates in those groups, it can be really helpful to enlist, try to work on enlisting the support of a leader within that group. Be it church groups, or in our town, our rodeo board, getting a leader or two interested in or seeing the benefits of vaccination, getting vaccinated, and promoting that to their group can impact a number of people.
Thank you for that. That is fantastic. And we've been working hard in Okanogan County to find those community partners that can do exactly that, be sort of champions and advocates within their group. So it's very important to build trust, definitely. How about, since we're running out of time here, Elias, can you give us a quick summary of what was discussed in your group? Take home points?
Sure. So we talked about the need for specific debunking resources so that providers who are getting questions can go to something to find out what that is about. And so I'll put together some of those resources for next time also. And then the need for just repeated presence. So one of the group members is part of a rural outreach where they went repeatedly to rural areas, and like every time they go, there's a few more people who are willing to be vaccinated, and giving them information that they can understand has really helped with improving uptake.
Great, thank you. Yeah, those resources are wanted. Our providers here in the county were putting this together. Definitely, we're anxious for other resources, like you said, besides government documents. So this will be really helpful to have a list. Lastly, Kathy, do you want to chime in and just give us a quick summary?
Yeah, I had a very engaged group. I would say most of the same stuff that I've heard already. The one that I heard also is the kind of idea of if it's required for travel. And so having awareness of, the need for vaccination prior to traveling, like on a flight or to a particular location. And then lastly, just that data that shows vaccinated versus unvaccinated, to understand the impact both from, disease to hospitalization and death. And that speaks to people sometimes to understand and continuing to go back. So, and talk about it again. So. Thank you.
Mm-hmm. It is very striking difference when we separate the vaccination groups and look at incidence rate. Well, that brings us to time, everyone. Thank you so much for joining. We'll see you back here next week at the same time. We'll have more opportunity for longer breakout sessions next week, and we'll also have a panel discussion, and we'll be joined by our 3 presenters today, as well as Dr. Wallace, Health Officer for Okanogan County. If you have questions that you would like to submit, the email address there on the screen If there's something specific we'd like to address in the panel next week, please do send an email, and we'll have a lively discussion again next week on Tuesday, July 20th. Thank you very much, everyone. Bye-bye.